Welcome to my topic of this webinar, normovolemic hemodilution, ancient or modern. It is very obvious that hemodilution, of course, is part of patient blood management nowadays, but if you take a look at the literature, you get the feeling that normovolemic hemodilution is something like an outdated friend, not used very often, and not too many publications are given about this topic. However, if you take a look at the literature at all, you can see that the first publication you can find in PubMed has been done in the year 1972 by the team of Konrad Messmer. Konrad Messmer was an surgeon, an experimental surgeon, who tried dilution experiments in laboratory animals, and he set the baseline for all upcoming investigations about acute normovolemic hemodilution. His main goal was to describe the central hemodynamics and the microcirculatory flow in the skeletal muscle. So you can see about acute normovolemic hemodilution, the first publication is now nearly 50 years ago. If I ask you what is the topic about normovolemic hemodilution, then it can be best described by this depiction here. Normovolemic hemodilution is consisted of removing blood from a patient and storing this blood with anticoagulants. The blood loss is then replaced by volume in order to achieve euvolemia, and during the surgical procedure the patient will lose blood that is diluted and contains less hemoglobin than the blood at the beginning of the procedure. After the procedure, the stored blood can be given back, given the theoretical advantage that the hemoglobin as well as the coagulation factors are given back to the patient, and so you can avoid to give allogeneic blood. Thinking about the physiology, you have to be aware of some facts. On the left side, you see the patient before the hemodilution step. You take away the blood, the first package of red blood cells. At the very beginning, without substituting any volume, you can see that the hematocrit stays essentially the same, because with the first blood bag, you lose plasma as well as the erythrocytes, and as a consequence, in the first step, the hematocrit stays the same. Only if you substitute the fluids, then you reach euvolemia, and as a consequence, the hematocrit will drop and you will see a reduction in the hematocrit. If you do this several times, in the end, you will have a patient with a low hematocrit, but on the other hand, you will have 3 packages or even more, depending on how often you repeat this procedure, of red blood cells that you can give back theoretically afterwards. These red blood cells are then ready for retransfusion, and usually they are given back in the opposite order as they have been taken. They have then the advantage that they contain red blood cells as well as platelets as well as plasma. One important discussion about acute normovolemic hemodilution in patient blood management is the question which solution should be used. It is the main goal that after this procedure you have a normovolemic patient, therefore this is called normovolemic hemodilution. This can either be achieved by the isovolemic application of colloids, or it can be achieved by a 1:3 ratio of crystalloids. And there are a lot of discussions which is the better way to go. For many, many years it was believed that colloids are the agents that should be used for this purpose. But on the other hand, nowadays colloids are more banned from the theater, and as a consequence are not used that often anymore. What you can see here is a publication in experimental animals, rats specifically, where they had 3 different groups, where they did a normovolemic hemodilution procedure has hydroxyethyl starches, crystalloids, and normal saline. And they took a look at urine output and tissue edema in this experimental model. You see on the x-axis the different hemodilution steps from the baseline to hematocrit of 15%. And as you can see for the different experimental groups, of course, there are significant differences in urine output, doing worst with normal saline solutions and doing best with colloids. What is discussed very often in the literature, that there should be a different degree in tissue edema, has not been found by this group. They did the wet to dry weight ratio for the kidneys, heart, brain, lung, and liver. And as you can see, no difference, no essential difference between these groups in any of these organs. So in earlier days, hydroxyethyl starches were the way to go. Nowadays, it seems as if we can use especially balanced crystalloids in the ratio 1 to 3, but we will see what the future brings here. If you take away the blood, it is discussed in the literature that the blood that is taken away for the purpose to give back should be stored on a shaker in order to maintain the function of the platelets. What you can see here is a TAC analysis of the blood taken away for 8 hours. And as you can recognize, there is no difference in the coagulation parameters, and no matter whether the platelets are rocked or unrocked. And as a consequence, for sure, it is good if you have a shaker in the OR, but not many ORs can provide that. If you now do ANH, the question is, what are the benefits? And what you can see here is a depiction of a calculated benefit of acute normovolemic dilution. In the first case, if you have no acute normovolemic hemodilution, you have a patient with a starting hematocrit of 45 or a hemoglobin concentration of 15 gram per deciliter. If this patient bleeds 1 liter, you lose 150 grams of hemoglobin, which is around about 2.5 packages of red blood cells. If you do a moderate hemodilution to a hemoglobin concentration of 7 gram per deciliter, the same amount of blood loss results in 70 gram per deciliter. And as a consequence, this is pretty much the same, like a little bit more than 1 package of red blood cells. And if you would do an extreme hemodilution procedure, have the same amount of blood loss, then you only lose 35 grams of hemoglobin, which is a little bit less than 1 packages of red blood cells. So if your patient bleeds intraoperatively, the lower the hemoglobin concentration, the less you lose blood in this situation. And as a consequence, this is the net effect of acute normovolemic hemodilution. Of course, this is only a calculatory example, and one might ask whether this holds true in a real-life setting. And there is a publication from the year 2015 where the group of Goldberg used acute normovolemic hemodilution in the cardiac surgery setting. It is a pretty huge study with in total nearly 15,000 patients. And you can see here in the middle of the table that they had 3 groups with ANH, less than 400 milliliters, 400 to 799 milliliters, and more than 800 milliliters. And they tried to find out whether there is an essential difference. And I want to focus you on the line which is called red blood cells. As you can see here, about 60% of the patients that didn't undergo ANH received red blood cells, but if there was a huge ANH volume of more than 800 milliliters, 70% of them didn't receive red blood cells. There are essential differences, and these differences depend on the amount of blood that is taken away in advance, so the theoretical advantage of ANH can also be calculated here. However, from the very beginning, there have been discussions about the efficacy of ANH, and this is one of the first calculatory examples where they try to say that there might be a little advantage in the use of AHA due to the calculation. If you want to calculate which hematocrit is reached and how much blood you can take away, there is essentially one old formula which has been published by Burke and Smith in the year 1974, where you can calculate the exchangeable blood volume, EBV, as the product of blood volume and a complicated logarithm. However, all these calculations have the problem that this formula doesn't describe exactly what takes place during acute normovolemic hemodilution. One of my first publications is dealing with this problem, and we could clearly demonstrate that all the formulas out there have an essential problem in describing whether acute normovolemic hemodilution is useful or not. What makes acute normovolemic hemodilution effective? You need a high starting hemoglobin concentration, you need a low target hemoglobin, you need a huge blood volume of the patient, and you need significant perioperative blood loss. If one of these is not existent, then the efficacy of normovolemic hemodilution will decline. If you take a look at the coagulation system of the patient, because it's often argued that normovolemic hemodilution results in a decline of coagulation function. Then you can see here in this ROTEM analysis that, of course, the values of INTEM, EXTEM, and FIBTEM change, but all of them essentially stay in the reference values of the respective parameter, and as a consequence, it can be said that ANH, of course, reduces coagulation potential, but not to such a degree that bleeding could be explained. If you take a look at the platelet function, then you can see that the platelet function is a little bit worse after ANH, but after giving back the blood, coagulation function, especially of the platelets, restores again. If you take a look at the coagulation function in the blood that you take away, then you can see that even after a storage time of 24 hours, the ROTEM values in the blood remain pretty much in the reference ranges, so it is nearly like giving back normal blood in this situation. So, are there any publications that can show that acute normovolemic hemodilution is useful? Yes, these publications exist, especially in the cardiac surgery setting. This is a publication of Shu from the year 2015 in Nestonalg, where they did a meta-analysis whether acute normovolemic hemodilution is useful for the reduction of red blood cell transfusion. And as you can see on the diamond on the bottom, yes, there is a difference which favors acute normovolemic hemodilution. If you take a look at blood loss, then you can see here that there is no difference in blood loss. As I've demonstrated, the coagulation factors remaining constant mean that not more blood is lost in this situation. They also analyzed the complications of acute normovolemic hemodilution, and as you can see, for mortality, for reoperation, infections, thrombosis, stroke, and renal dysfunction, essentially there is no difference between the groups that underwent normovolemic hemodilution or not. 2 years later, a new meta-analysis came out, essentially repeating the results that have been already published by Shu 2.5 years earlier. And 2 years ago, there is the third publication with the meta-analysis where again acute normovolemic hemodilution could significantly reduce the amount of red blood cell transfusion, and in this case even could reduce the estimated blood loss. So especially for cardiac surgery, it is warranted to use acute normovolemic hemodilution. There are, of course, some contraindications, and this is a publication from Schender and colleagues where it was discussed for cardiac surgery patients whether acute normovolemic hemodilutions should be used or not, and the indications and contraindications are given in this table, and if you do cardiac surgery cases, I strongly encourage you to take a look at this publication. So in my opinion, acute normovolemic hemodilution results in an anemic patient that loses less hemoglobin during bleeding. The harvested blood can be given back at the end of the surgery. ANH is effective if the starting hemoglobin is high, the target hemoglobin is low, blood volume is high, and bleeding is substantial. Today, ANH is often used in cardiac surgery. It is effective in this indication, and it is saved. If your patient has diminished anemia tolerance, you should not use ANH. So if you ask me, is ANH ancient or modern? The first publications in 1972, nearly 50 years later, a publication about the efficacy. Of course, the roots of ANH seem to be ancient, but it is still a method that can and should be used in clinical practice and is also very effective. Thank you very much for your attention.